गुड आफ्टरनून ऑल. गंगाखेडकर सर, गुड आफ्टरनून. 1-2 मिनिटं आपण थांबूयात. 1-2 मिनिटं. पीपल आर जॉईनिंग. जस्ट 3:34 वी विल स्टार्ट इमिडिएटली. चालेल? येस सर, येस सर.
रूपा.
हाँ सर.
Gangakar sir requested to finish this 10 minutes earlier. This was the second meeting at 5 o'clock again.
हो.
Some interview.
चालेल ना. Yes. Just take 2 minutes. We will wait. Few more people wanted to join. Technical काही थोड्याशा गोष्टी येतात ना. Just 2 minutes we'll wait. 3:34 we will start. प्रतीक सर, ऑफिसचा MCFच्या नावाचा कम्प्युटर पण लॉग इन होईल, तर त्याला पण को होस्ट करायला लागेल.
येस चालेल. नाव काय?
MCFच्याच नावाने, MCF नावानेच भरत लॉग इन करणार आहे.
येस करतो.
Should we start, sir? Shall we start?
Yeah. You got 60 positive. Yes, you can start.
Yes. Yeah. So good afternoon, everyone. I will request the office staff to start recording on office computer. Bharat. So good afternoon, friends. We all doctors the medical professionals. We keep ourselves updated with whatever the latest and the recent infections or diseases we come across in the current time. And during our practice time, as and when, like the COVID being the best example in last 2 years. So in current situation, we have been having the infection of measles, for which we have our very much our own Dr. Ganga Khedkar sir with us. So before we start with the actual session, let me walk you all through with the current projects of Mukta. I myself, Dr. Rupa Agarwal, one of the volunteer for Mukta Charitable Foundation. As you all know, Mukta has from the beginning has been working for HIV/AIDS through telephonic counseling in Pune and Bihar. Friends, many of you have various times attended various sessions with Mukta, but in case if any of us want to be part of us, definitely there are few opportunities with our current running projects of Shala Beyond Books, where we conduct sessions with school children of 8th, 9th and 10th students, where life skill education, HIV/AIDS, sexual health and addiction related talk we discuss with the students. Then with college students on gender sensitization, we walk them through little gender orientation and their queries related to various types of gender, and we try to make them aware of and make the other people, the normal common stream, what we will say the mainstream, to accommodate these minorities. Third, we have addiction related lecture series, and whoever doctor want to practice addiction related medicine or case management, they can definitely approach us, especially Dr. Prakash Mahajan sir, for the tips or learnings in that field. HIV and COVID related different questions, knowledge updation is definitely an ongoing thing. Colleges मध्ये, if any of you want to conduct session on addiction or gender awareness, we can help you become a good trainer. Mukta is also running a medico-legal forum where all kind of, not just allopath, homeopathy, Ayurvedic, all kind of medical practitioners will get regular updates and certain practical tips in contacts with their medical practice. And Dr. Jayant Navrange sir and the whole team of medico-legal experts from all over Maharashtra is on our expert panel. So we can definitely make use of their guidance in our rational medical practice. And the current project, which is in process of launch soon, is the mental health helpline that we are trying to deal from Pune and Bihar again, to deal with various mental health related issues, smaller to larger issues, where counselors with MA psychology and beyond expertise will try to deal with the calls and will be able to serve the society, walk through their whatever mental health issues in a more safer way, in a more containing manner. So with this brief introduction about various projects of Mukta, I welcome you all once again to this small forum of scientific lecture sharing. And since Mukta has always been working on scientific knowledge updation, this is one small effort where our colleagues, Dr. Mansi, Dr. Jayashri, Mahajan sir, and we are considering to have once a month kind of small awareness session on various medical topics for all of our doctor friends. So I invite Dr. Mansi to introduce the person who doesn't actually need introduction. Dr. Ganga Khedkar sir introduce करण्यासाठी I request Dr. Mansi.
Thank you, Dr. Rupa. Good afternoon, friends, and warm welcome. Currently, we are experiencing a measles outbreak in Maharashtra. Dealing with such epidemics needs an updation. Dr. Ganga Khedkar sir is the best mentor for the said topic. Dr. Raman Ganga Khedkar sir is a senior pediatrician
Mansi, voice.
India. He worked with the National Institute of Virology and National AIDS Research Institute, NARI, Pune, where he was active in developing national policies and patient empowerment. In his 2-year stint with ICMR, he was active in handling the Nipah virus outbreak and the 2020 COVID pandemic. Over to you, sir.
Thank you. Madam, मला शेअर करायला दिलंय का?
Yes,
Uh,
yes, sir. Yes, you are co-host, so you should be able to share.
1 second.
Yes.
Yes, sir.
Perfect.
आवाज clear आहे ना, madam?
Yes.
Ho, sir. Ho, sir.
So today, I'm going to perhaps walk through my young adulthood and think about measles, which used to be so common, and now suddenly you're worried about the outbreaks, despite the fact that you have a highly efficacious vaccine. So let's try and look at, just give me a couple of minutes. Huh? Just try and look at why should we be bothering about measles and rubella per se. So one of the things which we have to remember that close to about 128,000 children lost life due to measles in 2021. Measles can cause SSP and other fatal neurologic diseases in 7 to 10 years of after infection among those who are by and large likely to be less than 2 years of age when the first episode of measles has actually occurred. A third of these congenital rubella syndrome cases, they tend to die before the age of 1 year. And rubella is a leading cause of miscarriage and stillbirth. And what is most important, they are both vaccine preventable infections. The vaccines are highly efficacious. Now, when we think in terms of measles and rubella elimination, why should it be a priority in Southeast Asia region? One must remember that measles globally, 11 lakh cases of measles can be prevented if we go for elimination. Each case that we prevent, it averts 2 weeks of daily that otherwise would have been lost, the disability adjusted life years. Until 2023, it is estimated that if we go towards good elimination efforts, 11 lakh deaths would be averted from between 2020 and 2023. The average cost of each death that is averted is far too smaller. It's only about $1,373 US, and that's something which every country should be willing to afford. Congenital rubella syndrome, India contributes 38% of cases of congenital rubella syndrome even now. Now, Delhi that we avert per case is close to 27 years. That's significantly large kind of a number. The management cost, if we were to look at middle income countries and if a child is born with CRS, would be close to about 57,000 because of the teratogenic effect that it tends to have. And 52,000 odd CRS cases can be prevented every year due to the vaccines that we provide. Now, if you actually look at, just 1 second, this is the deaths that we have so far prevented from measles. If you look at this particular graph, you will realize the upper line actually is for those people who would have died in absence of vaccine. And if you look at the lower line, you will find that with the vaccines, we have reduced this number and the gap widens so much significantly that there is every reason to believe that these vaccines have to be provided to these children. Now, if you look at our own performance so far with universal immunization program, which we started, and even up till now, if you actually see, you will find that a significant achievement has been done in the number of cases that we have been able to reduce through provision of vaccines for a variety of organisms, whether it is diphtheria, tetanus, polio, measles, or pertussis as such. which means that we can probably perform really well. And today, when you talk at the backdrop of COVID, we know adult vaccination we could provide perhaps in a very high proportion in a short period of time. That's something which was unimaginable for a program which used to perhaps only focus on children for provision of vaccine or pregnant women. But if you actually look at our performance of recent for measles, you will find in Southeast Asia region, there are 5 countries which have reported that they have eliminated measles. And 2 of them, Maldives and Sri Lanka, have reported it consistently for 3 years' time, which essentially means that we are nowhere when it comes to elimination. We are not part of these 5, despite the fact that immunization program is one of the best programs that we continue to have. Now, the greater challenge for India, if you actually look at it, elimination of measles, control of rubella, and elimination of congenital rubella syndrome was one of the goals or targets for 2020. And obviously, we could not do it. But if you actually look at it, we had to reset the goal for entire Southeast Asia region. Measles and rubella elimination is now for 2023. But we had almost the COVID, which was affecting almost for 3 years the entire public health programming strategy. And even now, in the end of 2022, we are now thinking in terms of changing the goalpost, and probably we may have to look at a different goalpost now in terms of when we will be able to eliminate. And that's one part that is coming to the mind of all those who are public health strategies as of now. Now, if you look at the number of cases that have occurred, if you look at Indian data, you find that the numbers have declined from 2017, when it was about 14,000 or 18, we had about 21,000, and slowly dropped to close to about 5,000 in 2021. But the most important thing that we have to understand, that majority of these cases were occurring between 9 months to 4 years old children. And that's something which we have to keep at the back of mind, which tells us perhaps our vaccine coverages probably were shorter in those age groups per se. If you look at the dosages of measles vaccine that we have provided, you will find that 14% of these cases that were occurring, they had received only 1 dose, and about 17% had not received any vaccine in 2021, and 32%, close to about 30%, has been a standard figure throughout, where we do not know the vaccination status because of poor reporting or incorrect filling of those forms. And that's something which we have to keep at the back of mind. Now, if you look at the impact of our vaccine coverage, especially the impact due to COVID that has taken place in India. Now, if you look at this particular figure, this particular graph, you will suddenly find for measles first dose, you find that the numbers tended to go down. They went down from 94% coverage that was there in 2019 to almost 89% in 2021. If you look at measles second dose, you find the numbers drop down still further. You find that the number came down to about 82%. And for rubella, you have almost the same number as measles first dose, mainly because that is 1 dose vaccine that is provided through program. What does it mean? Even a small drop in percentages that tend to occur for a large population size like in India, you'll find number of cases that tend to occur tend to be far higher when compared to the rest of the countries. If you look at the top 10 countries where the infants have not received the first dose of measles vaccine, Nigeria tops the list, as in 2021, they have close to about 31 lakh. These are all estimations, 31 lakh children who have not received even single dose of MCV, that is measles vaccine. But the second number comes to India, where we talk of 25 lakh children who have perhaps not received the vaccine. Now, that's something which is a worrisome figure, and we need to overcome the challenge that is associated with such an issue. what do we need to know about this particular measles virus? That it belongs to Paramyxoviridae family and morbillivirus genus per se. It's an enveloped single-stranded RNA virus. It has 6 structural proteins, 2 non-structural proteins, and a structural protein called the hemagglutinatin. It tends to attach to the host cell and infect an individual. Interestingly, most of us know that RNA viruses tend to mutate far faster compared to other viruses as such. This virus is monotypic serologically, which essentially means it doesn't affect the antibody responses as dramatically as much as it may mutate. We don't have a problem of antibodies trying to thwart or protect us from getting this particular infection, and therefore we talk of lifelong immunity once you get infected per se, which we will try and understand later. It has close to about 24 genotypes because this is a RNA virus. They are distributed in 8 different clades. Globally, you have D3, D8, and H1, which are predominant genotypes. In last 2 years, whatever genotypes we have seen in India are largely D8, D4, and a small proportion in D3 per se. Now, though there are many genotypes, they do not impact the virulence of the virus or severity of illness, including development of SSPE, which is a redeeming feature with this particular infection as such. That should perhaps help us fighting this much better because we don't have issues with increase in virulence. However, these genotypes, though they don't have differences in virulence, we continue to monitor them because the worry is a new genotype may emerge and may pose a challenge across per se. Who are at high risk of developing complications in measles? They are essentially infants and children under 5 years of age, adults above the 20 years of age, pregnant women, immunocompromised individuals like HIV-infected individuals or patients who have developed malignancies. If you look at transmission of measles, it tends to spread through cough or sneeze. It can affect and infect others in 4 days prior to development of any rash and 4 days after the rash is visible. So essentially, it's very difficult to protect oneself if you come in contact with such an individual or an index case per se. It can infect 9 out of 10 to whom you are exposed to, and if the individual is unprotected, neither has he taken vaccine, so there are no antibodies within, or did not have infection in the past, you will find 9 out of 10 such contacts will become infected by measles virus from the index case per se. Now, if your R0, which is related to transmissibility, is far higher than other viruses like measles, it currently is estimated to have 9 to 18 for R0 value. If you compare that with Omicron, it's up to 15. Polio, it is 4 to 13. You look at smallpox, it is 5 to 7. The higher the value is, there are certain things which we have to understand with respect to R0 values. One requires about 95% of the population to be protected so that you can interrupt the transmission that can occur in the community. So every outbreak that tends to occur in the community has to be taken as a challenge, and we have to try and stop that so that you don't expose the other vulnerable population and lead to issues around elimination per se. Our strategy, which has been adopted in India per se, you find that this strategy revolves around SIAs. And what is SIA? These are special immunization activities where they hold different camps. Wherever the major outbreak has occurred, you will find that SIAs are conducted, door-to-door surveys are done, and they try to ensure that vaccine is given to most of those who have either missed dose or whatever. But when we say that this all depends on where the outbreak has occurred. We need to know what is the definition of an outbreak. The definition is when there are 5 or more suspected measles cases that are reported in 4 weeks in that particular area, or 2 laboratory confirmed cases that have occurred in a geographic region. You call that there is an outbreak that has occurred, and it should trigger one's response to develop these SIAs and try to ensure that you protect the families from getting this infection across to other people. Now, if you look at the approach that we have adopted of SIA, you will find there is a catch-up that has occurred definitely with vaccine coverages for measles as well as for measles rubella. When we started SIS per se, and when MR vaccine has been delivered to people at that juncture. So naturally, it means SIA is perhaps one of the better options to ensure that the coverage tends to improve. Now, when we think in terms of what symptoms may actually arise, there are certain things which we must remember, that the incubation period is between 7 to 14 days. They present with high-grade fever. They would have cold, cough, and conjunctivitis. Within 2 to 3 days of these symptoms, you will find Koplik spots, which we will see subsequently. They appear. The rash breaks out within a day. Once you see the Koplik spots, it is initially macular. It starts on the face or near the hairline, and then it spreads all across the body. Then it becomes, not popular, papular, and the fever spikes tend to be the highest at that juncture when the rash covers all the body per se. Within a few days, it starts fading. You will also find that certain symptoms, like certain conditions like otitis media and diarrhea, are also likely to occur during acute phases. If you want to look at Koplik spot, unfortunately, now I don't have pictures of our own, but if you look at Koplik spot, you will find that you see a red lesion around the cheeks per se, and that tells you that perhaps it warns you that this could be measles per se. Now, if you look at measles skin rash after 3 days, it's classically maculopapular. You'll find that it first starts on the face and then slowly it spreads across the entire body. How do we diagnose this particular infection? Beyond the clinical diagnosis, one needs to collect blood, nasopharyngeal swab, and urine if it is possible. Serum sample is used to detect the measles specific IgM antibodies to find out whether the child has measles per se. RT-PCR is done to detect the virus, and that's very important to also be done. And both the things can be done through Pune. At least has one good thing, that you have National Institute of Virology, where you can get these tests done free of cost. Phenotyping is done to identify the source. When an outbreak tends to occur, if you do genomic sequencing, one possibility that tends to become more conducive is you can find out whether the virus in that outbreak is similar among multiple cases that have occurred, so that you can zero down on the source of infection that is there. And also distinguish between wild type infection and the rash that can be caused by vaccine, because this particular vaccine may lead to development of rash. And therefore, if you want to distinguish, the best way is doing genotypic assay. Now, when it comes to measles, if you think in terms of complications that you might see, with respect to hospitalization, 1 out of 4 cases are likely to get hospitalized. 1 out of 1,000 cases may come out with encephalitis as one of its complication, and 1 to 2 cases out of 1,000 cases are likely to die due to this infection. And that's something which we have to keep at the back of mind, though it doesn't look as a major kind of a challenge even now we must remember that the likelihood, if this continues to spread because of different reasons, which we will try and see subsequently, if it spreads, it has a high morbidity and mortality, which we need to reduce by providing vaccines. The CFR, case fatality rate, in children between 1 to 4 years is close to about 0.505% in developed countries. But when it comes to countries like ours, the rate tends to go up. It goes to close to about 6%. And that's another thing which we have to remember. More often, you will find these deaths tend to occur because of pneumonitis and underlying malnutrition, especially vitamin A deficiency. And therefore, even suspected cases of measles, we tend to provide 2 dosages of vitamin A to all of them. Now, what are the major severe complications that are associated with measles infection? You could get primary measles encephalitis. One could get acute disseminated encephalomyelitis, which is a demyelinating disease. The risk is close to about 1 in 1,000 among those who had measles. Most often, it is commonly seen among children who are beyond the age of 4 years. Measles inclusion body encephalitis, this tends to be a fatal kind of outcome is associated with it. It is commonly seen among those who are immunocompromised, and that's mainly because the infection tends to be persistent among these people. So the virus continues to stay within and creates issues for us to worry about. Subacute sclerosing panencephalitis, which is one of the most dreaded complications. It is SSP, called as SSP as a short form. This is a rare, progressive, fatal neurological disease. And the risk of this particular disease lies anywhere between 1 in 9,000 to 1 in 15,000. And to my mind, if you look at the number of children who might get infected if there is a serious outbreak, perhaps you find that these risks actually transform into reality because the denominators tend to be high. And this tends to occur within 7 to 10 years of infection. And that's something which is also an issue that we have to remember. Most often, you tend to ask them history of measles in the past, which generally turns out to be positive. Now, if you look at the incidence of measles in India, where are we? You find that from 2017, it was 10 cases per million population. 18 had the highest, around 15. And then there was a rapid decline that occurred up to 2020 because of the vaccination coverage that was improving and the special activities that were being conducted as camps, they were improving our coverage. But in 2020, COVID struck us. And then you find that in 2021, the incidence has increased slightly, but that's a worrisome sign because not everything tends to get reported. And that's something which causes a lot of concern for all of us at this juncture. When it comes to measles in Maharashtra state over last 4 years, you will suddenly find that suspected cases number suddenly started rising in 2021 and 2022 during the COVID period. Even the numbers for those who have been confirmed with a lab confirmed diagnosis, you find that the number has now suddenly jumped up to 1,050 in 2020 up to 15th of December 2022. And that is a big worry, whether our vaccine coverage has been worse affected in this COVID pandemic per se. Now, if you look at districts and find out which district tends to have higher numbers of lab confirmed cases, Mumbai tends to have the highest. Then you have Thane, then you have Malegaon, Bhiwandi, and then now Pune is coming up. If we look at the numbers, now number as of today is 26 from Pune. If you look at the cases that have been reported in Pune, which areas they tend to live in, it is Bhavanipet, Kondwa, Katraj, Vanodi, Kadiwala Road, Hadapsar, and Mangalwarpet so far. So what is it that the government Now, if you look at if you look at the age groups of 20 deaths that have occurred so far in Maharashtra, you suddenly find that the number tend to be high for 12 to 24 months age group. And that is a big worry. And that's perhaps a reflection that they have not received the vaccine and therefore they got infected. Whereas those children who were younger may have been protected to some extent by maternal antibodies. And that's something which we have to keep at the back of mind. If you look at the gender distribution, it's same, it is equal, excepting one child of all those 20 that has died. That particular child had received one dose of MR. The rest of them had not received any vaccine, and 13 of these deaths have been reported from Mumbai, which is not very unusual because you look at the denominator is very high for Bombay compared to rest of the state. In response to this outbreak, what is it that the government is doing? It is doing door-to-door survey and SIA, that is special immunization related activities. Any child between 9 months to 5 years who has missed even one dose of MR, they are providing two dosages with 28 days interval to all such children to ensure that they would remain protected. Provide vaccine to those who are eligible across the 9 to 12 months, you give first dose of MR. Then 16 to 24 months, you give second dose of MR. If you look at IAP recommendation, they recommend the third dose between 4 to 6 years, more for the reasons that the protection from mumps would actually come in if you use MMR there. Provide vitamin A to malnourished children. Provide 2 dosages of vitamin A to all suspected cases and mobilize private practitioners, Unani doctors, and the community to try and ensure that this outbreak doesn't extend to other vulnerable population. When we have these issues, what is it that we can do? You can even provide post-exposure prophylaxis. We could provide, this vaccine to those who are vulnerable and had even definitive exposure per se. Those who are likely to develop any complication to underlying conditions, you may still provide MMR vaccine. MMR vaccine can be provided within 72 hours of exposure. IgG, perhaps is not available in India. At least I am not very confident about its availability. And what is important is the cost tends to be high. It has to be provided within 6 days of exposure. But we need to remember that we should not be providing MMR as well as this IgG together because you want the take of vaccine, if at all, if it is possible, to protect the child per se. If you look at history of measles vaccine in India, our indigenous vaccine production started sometime in 1980s. UIP included measles vaccine in 1985. 2 dosages of measles vaccine were introduced in 2010. Initially, it was only 1 dose. 2 strains of viruses have been used for development of vaccine. The Schwartz and Edmondson Zagreb strain has been used there. But over a period of time, we have settled for using Edmondson Zagreb measles strain in our vaccines. If you look at the efficacy of these vaccines, the efficacy of these vaccines is fairly high. If you look at seroconversion after first dose for measles, it is close to 96% as a point estimate. And if you look at 1 dose vaccine effectiveness, it's close to 93%. And if you provide 2 dosages of measles, you'll find that the effectiveness is close to about 97%. But you must also keep at the back of mind about the data about duration of immunity. For the first dose, it can protect you up to 11 years. If there are 2 dosages, it protects you up to 15 years per se. Rubella vaccine is also highly immunogenic, and therefore you are also finding that seroconversion rates are extremely high, 99% as point estimate and 97% for vaccine effectiveness as such. So that's something which makes us think that we need to intensify our efforts to enhance our vaccine coverage. Now, still, you find that people don't receive the vaccine. Now, what is it in that you need to understand? Or there are people who don't have that even, they tend to get some kind of information which could be misleading to us. Most often, you will find that people may provide this vaccine to children who are younger, and that's something which has to be avoided. But estimation of age can be wrong. It is possible that it could be vaccinators' convenience or parents' convenience, that they don't want to come again after a month or 2 months, whatever. Incorrect age estimation perhaps may lead to provide this vaccine in presence of maternal antibodies, and therefore the take of the vaccine can be affected to a significant degree. Now, what have we learned so far about maternal antibodies? It tends to rely upon a data which was generated in 1990 by Weisberg. Now, most often we tend to believe that the maternal antibodies tend to disappear by the age of 9 months. No? It slowly starts falling, and then it almost gets to uh, 10 times lesser, in terms of the titers, and therefore these maternal antibodies, we think, may not cause any kind of problem in having a good immunization take per se. But if you look at the data when it comes to measles antibodies, if you look at seropositivity among infants who have not received the vaccine, which essentially means the maternal antibodies were actually found out in the baby's blood. If you actually look at it between 10 to 12 years, in this small study, they found that 20% of them still continue to have maternal antibody present, and 10% had maternal antibody despite the fact that the age was 13 to 15 months per se. Now, when you provide vaccine, the seroconversion, if you are providing it very early, the seroconversion keeps on rising as the child tends to get old and older. But one must also remember that it doesn't go closer to what you would like it to happen, towards the very high seroconversion rates of 95, 96%. You don't achieve those levels if you provide it early. When you think in terms of other issue that tends to arise, is the storage condition for MMR vaccine. These need to be kept. They have their own special, though these are lyophilized vaccines, so they have to be in deep freezers. Now, when you use this lyophilized vaccine, you have to reconstitute vaccine with the diluent that is provided with the vaccine itself, and store it at 2 to 8 degrees only up to 8 hours time. The longer you store, perhaps the vaccine loses its potency. We must also remember that the issue tends to remain similarly for the diluent per se. Now, despite highly efficacious vaccine, why do these outbreaks occur or continue to occur in India? Lower importance is being given to the vaccination due to low health literacy and poverty by the community per se. You find there are certain religious kinds of concerns that certain communities would have, and they refuse to take these vaccines per se, as it has been a story even in polio for that matter. Not taking vaccine second dose is one of the other common things that tends to happen. Most often, it is associated with migration, because they keep on changing. If people migrate after taking the first dose, when he goes to a new city or a new place, he may perhaps not know where to go and take the vaccine. The impact of maternal antibodies on the take, which depends on the age of the child at that juncture when the first dose has been provided. Incorrect reporting of vaccine coverage. This is also a possibility which none of us can ever rule out. Maintenance of cold chain, which is also an important issue that we talked about. And we tend to have many missed opportunities to advocate for taking these vaccines And that's another thing which we have to keep at the back of it. From where do people take MR vaccine? Now, one of the most important issues that we have to understand is one tends to feel, because we as medical professionals come from a slightly higher socio-economic strata, and therefore we tend to think everybody goes to private sector. We tend to think that those who are educated, all of them take the vaccine from the private sector, and therefore there is we need to ensure that we follow these issues rigorously in private setting. But the reality could be little different. If you look at the proportion of people who go to private sector, the proportion was found to be close to about 11% itself in 4 districts where the survey was being done, which essentially means the focus continues to be on public sector. But even if it is on public sector, what is also important for us to understand is we need to provide certain kind of support to the public sector. Now, what is it that one could actually think about? If most of the people tend to take vaccines from public sector, what should our private practitioners do? We should ask history of immunization to all the children who come to you, irrespective of whichever branch you belong to. Counsel every pregnant woman, if they come to you, about importance of vaccines, especially MMR. Can we display immunization schedules in waiting rooms, even if you are not a pediatrician? Is an issue which is an open-ended question. We should think about it. Most importantly, inform public health officials if you have seen any suspected case. I have purposefully given the number of Dr. Aute. You could also contact PMC or PCMC. Aute comes from IDSP background, integrated disease control, integrated. I'm sorry, I lost it. IDSP program. So one could actually approach and inform him. They will follow up with the action that they have to take. Together, we must eliminate measles as soon as possible. I need to remind adults above the age of 20 have a higher risk of complication if they acquire it. And why is this a worry? Because please remember that duration of immunity is not lifelong as we would like to believe. So essentially, unless we stop measles, perhaps there is always a risk or a likelihood that it may come back and hit people who are older or immunocompromised subsequently. So let us work together for the health of children and also us indirectly. Thank you.
Thank
Dr.
you, sir.
Jayashree?
Yes.
Sorry.
Unmute. जयश्री मॅडम अनम्यूट करा. अनम्यूट प्रतीक. जयश्री मॅडम म्यूट.
Yes.
Huh.
Thank you, sir, for such a wonderful lecture. There are some questions in the chat box. Shall I ask them?
Yeah, please.
So the first question was, what is DALI? You mentioned.
DALI is disability adjusted life years, which
Okay.
means if I have a fracture and I am asked to stay at home for 2 weeks time. So I have lost 2 weeks of my life unnecessarily, which was avoidable. Because this is the way you try to measure cost effectiveness. You must imagine that if you are sitting in NTAGI, which takes decisions on which vaccine to be introduced in the program, it's a very difficult choice. You cannot just go by cost. You have to look at disability adjusted life years, and then you calculate how much of money am I going to spend for each disability adjusted life year that I'm going to save. These are difficult calculations, but they have to be done to introduce any new intervention into programs. It's not very easy. It's also called as health technology assessment, no? Which we do in that manner.
After how many days measles antibodies develop?
Measles antibodies develop quickly. It's a highly immunogenic virus.
And what is the quarantine period for measles?
Quarantine period could be 2 to 3 weeks time.
Okay.
If you look at incubation period, if it is 14 days as maximum that we are keeping in our mind, then in those cases it would be almost 2 times higher, but conservatively it can be up to 21 days.
Next question, I think you have answered. A child age of 4.5 years not received any vaccine, how to proceed?
You have to provide the vaccine. There is nothing else.
And the gap of 28 days, you told, the second.
28 days, if they are staying in a high-risk area where outbreak has occurred. Because you want to see that the child would develop protective antibodies. So giving both the doses within 28 days time, you try to enhance the chance that the child won't actually acquire measles. Therefore, it is done rapidly.
The next question is, MR is given by BMC. We have MMR vaccine. Why MMR is not given instead so that we can cover mumps also? I think you told.
No, no. This all depends on, as I said, we talked about DALIs. No? Then you look at the morbidity, risk of death, and you make calculations to suit your budgets, no? That you have at disposal. Mumps, if you look at the likelihood of complications, they're not life-threatening. This doesn't mean MMR will not come into program. It's only a question of time. No? You have to prioritize different vaccines. All of us might feel that India has now provided COVID vaccine free, why not MMR? But unless in those calculations, it comes out as cost effective, it's very difficult to get in. Because there could be people who will advocate for pneumococcal vaccine. There are people who advocate for meningococcal vaccine. For certain groups, it may be really important, but that doesn't mean it can become easily the part of our immunization program. And therefore, the middle and the mumps, perhaps not given in the program per se, because of the cost issues, to be honest.
Next question is about the treatment part. If we find Koplik spots in the child, how to manage a child at that time? Should we start some antiviral medicines?
There are no effective antivirals.
Okay. And what are the initial symptoms of SSPE?
Initial symptoms, it is, it will be followed with demyelinating disorders per se. The person would be paralyzed slowly, progressive paralysis tends to occur. The child will also develop speaking difficulties per se. The entire incidence has come down as of now because of vaccination. But it's one kind of an ailment where you feel frustrated because you feel helpless. You can't do anything to that.
What is your advice to girls and boys of 25 to 30 years age having completed timely childhood vaccination who are about to marry?
No, I didn't get.
What is your advice to girls and boys of 25 to 30 years of age who have completed timely childhood vaccination and who are now going to marry? So any advice for them?
That would be the best thing to do as an intervention. No? When you have pre-marriage counseling as a part of it, it would be always good to add a small component of what they should be doing to take care of their own babies. Vaccination becomes a part of it. Perhaps nutritional advice related to breastfeeding, if it becomes a part of the whole thing, things can be entirely different. But unfortunately, the trend of premarital counseling has not caught up as much. We really don't know. There was a time in HIV, people perhaps were willing to go for premarital counseling, but that trend is gone now.
Yes, sir. I think you have answered. How much is the isolation period advised now?
Yeah.
Initially, we used to give 1 week rest period to the child. Now is, I think you told 21 days, no?
Yeah, minimum of 21. There is a formula. No? When you look at incubation period, ideally it should be 2 times higher. No, the incubation period, and if you still want to minimize it, then it could be 1.5 times more. So it all depends on the circumstances, the kind of outbreak that you face. You saw a similar thing in COVID also. No? Initially it was 14 days, then it came down to 7 days. For Omicron also, we went right up to 5 days. It tends to become less and lesser depending on incubation period.
Next question. Many kids are missing the 9 months and 18 months doses. Coverage is around 65%. Is there any tracking system with government, as maximum vaccination at government settings is to find out who have missed? So any tracking system with them?
Tracking system they have. No, the data is entered, but the data is so huge that you cannot analyze so easily at a state level. So ideally, a decentralized approach at a district level could work very well, because there the numbers are small and they can decide who has come and who has not. Are we using it appropriately? I doubt that. In COVID, in last 3 years, the public health system, entire public health system was at the mercy of COVID-related activities. And therefore, there has been some amount of, which word should I use? There was low priority that was given to other programs. And the result is the impact on immunization has been significantly higher, because every family wanted to protect their child from getting COVID. So they did not go out. Neither the health workers were able to go to them. So the result was there is a decline. To my mind, what we see as numbers may be an overestimate of the reality, because people may not admit that vaccine coverage has dropped because of COVID.
So there is one question regarding myoclonic jerks. I don't think so. Is there any symptom like myoclonic jerks in measles or any side effects?
Rarely.
Complications regarding? No.
Yeah, rare.
So there is one question from Mansi Pahade. Though the session is on measles, please throw some light on recent outbreak of COVID in China, as there is high alert in India.
One thing which I can say is, see, we had done good strategic planning. We have done really well in terms of controlling this particular infection. I'll tell you why. No, China had the best chance, to actually lift the zero COVID strategy in stages. Unfortunately, because of pressure, what they have done is they have suddenly stopped the zero COVID strategy, and everything has been opened up because of public pressure through whatever demonstrations had occurred. Now, what is the significance of that? If you look at the R0 value of these new variants of the Omicron sublineages, you find that this continues to be higher. No, it ranges right up to 15, which essentially means one individual within a day. It is within a day mainly because this is now becoming highly transmissible infection. He may infect about 15 odd people, 18 odd people. So entire family gets infection. Whoever comes in contact will get infection. The edge that China had was they never had that severe Delta wave, because they had stopped through zero COVID strategy. But now when they have opened up, even if it is Omicron, the virus may be mild, but at the same time you find that it also can kill people, those who are highly vulnerable, those who are older, those who have not taken vaccine or with chronic morbidity. Now, what is the biggest worry for them? The biggest worry is they have relied on a vaccine which was similar to Covaxin. They have given Sinopharm and Sinovac to all the people. Their coverage rates are pretty high, to 90%. Now, is there a difference between Covaxin and Sinopharm, Sinovac? Yes, there is a big difference. The adjuvant that we have used, which is Alugel for Covaxin, is one of the best adjuvants that we have now for these live attenuated vaccines per se, whole inactivated vaccines. Now, these people did not use this Alugel because this was a new development. It was only available in US and people had to import from US. Now there was a shortage. So they used the older adjuvants. And if you look at their data of vaccine efficacy, it ranged from 47% to 70% that was reported. Many countries who did their own studies to begin with dropped the Sinopharm and Sinovac vaccine because they found it was not worth it. Now, given this development, what will happen? You will find that there will be a very sharp wave of Omicron. You might suddenly find tens of millions in different parts would get infection. People who have received vaccine since it was of lower efficacy, the death rates will be higher among those who are vulnerable. Now, when we think about these issues, one issue that comes to people's mind as a question, will there be a new variant that may come and will it threaten us or the entire world? To my mind, this is my personal opinion, I don't think it will come. The reason is this virus has a very short incubation period. It's about 3 to 5 days. If it has a very high transmission efficiency, the waves will be very rapid, rapidly escalating. And you will find decline will also come down, will be faster. The result is, my gut feel is, we used to have in our COVID outbreak about 4 to 5 months time for each wave to be there. You found in Omicron, the wave ended very sharply. It took almost 2.5 months time. My gut feel is in China, perhaps you will have only 1 month's time for the infection to come down because they are completely vulnerable as of now from every intervention, which actually they could have done really well. But what would it do? It will not give adequate time for the virus to change or to mutate because it's going to stay within the body for a short period of time. It will be infecting large number of people in very short period of time. So to my mind, new variant, which would have higher risk of hospitalization, which can threaten with higher mortality rates or case fatality rate, is unlikely to come. But this doesn't mean I could be correct. We are also learning, but we will have to keep a vigil on this particular variants that emerge or get reported from China. What is also important is all those who are elderly, all those who are vulnerable due to chronic morbidities, they must ensure that they have taken a booster and also ensure that you wear a mask. It is not going to be otherwise challenging.
Yes, sir. Moving back to our measles group, what are the advantages of measles being a notifiable disease?
That is because if you want to have an elimination target, you should be able, the number of cases that occur in a large geographic area as sporadic outbreak. If you don't make that notifiable, government may not come to know if the healthcare infrastructure doesn't exist. So the government's intervention activities cannot reach there in time. And the outbreaks may actually become large enough in communities. So you have to make those diseases notifiable if you are coming closer to elimination. And as we saw in that slide, our numbers had dropped down dramatically, almost close to about 5,000 cases in a country which is so large in terms of population. Unless you make them notifiable, we cannot do that. And there is a surveillance that is also done by public health people in the system with an effort to find out whether measles or rubella has occurred. So you have to make every effort. See, when you come so close, you cannot stop at any intensified activity, because the only thing that you can do is bring it to such a level that it is eliminated, and then you have mentally got to think, can I eradicate this virus so that that threat doesn't exist? It's like smallpox, no? If you remember, for smallpox also, it was a notifiable disease.
So one question.
Madam, now I must
Okay.
go.
Okay, sir. Thank you, sir, for such a detailed explanation about the measles. Now I request Dr. Prakash Mahajan, sir, to sum up the session.
So just one small question you might answer in short. I know you're in a hurry right now. You talked about notifiable disease right now. Today morning, I got a call from Dr. Navaringe, Sir Jain Navaringe from IMA. He is the head of the medical legal side. He said, I notified 2 patients of measles just last week to PMC, and there has been no response. What should I do now? Or is it not necessary that they respond and come back to you? Is it enough to just notify and they'll keep it on record?
No, there are 2 things which we have to remember. When you notify, you are saying this is a suspected case. No, they will confirm it in the labs that are notified to conduct those tests and come back to that particular person. They may not go to the doctor, no, but they will go to the local area where they are staying and go for door-to-door campaign to find it out. So it is not necessary that it will happen in real-time basis. It still takes time. That's a sad part of it. Because though I said it is in NIV that these tests are done for MR surveillance or this measles and rubella surveillance, the work actually is also being done in NIV Bombay. So there is a transit time. The results tend to come little late. That happens. But despite that, we should keep on notifying. That's the best thing we can do.
Thank you, sir. Next 3-4 minutes, I'm going to talk some good things that has happened in the past between Mukta Charitable Foundation and Dr. Raman Gangakedkar. So if you're in a hurry, I think I can talk to the people there. Sir? Sir, गेलेत का?
नहीं, hang झालंय.
हाँ, बोला.
The next 3-4 minutes, I'm going to talk some good things that have happened between MCF and Dr. Raman Gangakedkar in the past. So there will be a lot of praise. If you are feeling uncomfortable and in a hurry, sir, I'll talk to these people.
Yes.
Okay.
Yes,
Huh?
Thank you, sir.
Yeah, thank you. Thank you very much, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Right.
Thank you.
Hello, friends. I told Dr. Gangakedkar some good things about MCF and Gangakedkar, sir. You know, we know Dr. Gangakedkar for quite a long time now. See, we started with an HIV lecture series. Dr. Raman Gangakedkar, he was in NARI in various posts. He was the chief of scientific research projects, and then ultimately became the NARI's head, director. So we know, and during that same period, we were starting this HIV helpline, and we are conducting HIV lecture series for doctors all over Pune. We conducted, I believe, almost 13, 14 lecture series all over. And every time Dr. Ganga Kedkar sir he was always with us to give lectures and teach doctors. So that's how our association with Dr. Ganga Kedkar sir developed. He's always been with us all the time for so many years now. And of course, he has helped me and help us like a mentor throughout this HIV, Samvad HIV helpline that we developed. He was always behind us and supporting us all the time. And to tell you right now, see, I received a call from Dr. Ganga Kedkar sir just about 20-25 minutes prior to the beginning of this particular session. And he told me, sir, please, my 10 minute kami kara. I have been under great pressure because of this COVID wave. So many people are calling me because I want to give lectures like this. Almost 4 I received calls since yesterday evening. And Rajdeep Sardesai, the government of India's government of India's official person, he also requested me to talk with us right now. If somebody wants to come at 3:30, somebody wants to talk me at 4 o'clock. Z News, they are calling me at 5:15. But I receive every day because it's a government thing. I was working in a government job. Doordarshan, I have to speak to them person at 5 o'clock. So I have to leave early. So I thank you profusely. But look at that, he didn't think of canceling this particular session because he was requested for so many interviews. So that's our association with Nauranga sir. And I'll tell you what has happened, he's absolutely a down-to-earth person. Why I'm saying that, see, basically, when we met him initially, so many years back, 15, I think 2 decades back, first, here we had put a lecture in, I think, Sanjeevani College. So how did he said, he was in America. He was giving a lecture he was WHO consultant for HIV. He was talking to a big conference, all powerful HIV specialists from all over the world. And he was doing his research papers. So he did that. He came by flight at night. He came in the morning next day. He talked to about 150 doctors all over Pune about HIV. He taught them about that. Next day morning, he went to a school and sitting by the side, 600 students, told them about asexuality. Right from WHO consultant in New York to school children, he doesn't feel anything. He's absolutely down to earth. So, and of course, he understands everything. He understands everything. He's very comfortable with everything. I remember a very good incident when we are conducting this HIV lecture series. We are conducting this in every part of Pune. Then we went to suburbs. Then one day we went to Lonavala. Every time we used to get a response of 150, 100 doctors, 75 doctors. In Lonavala, you won't believe it. Only the president of that association came and only one doctor attended the whole thing. I myself, Dr. Pujari sir, and you already know him, Dr. Ganga Kedkar sir, Dr. Vinay Kulkarni, Rupa, Madhu, we have been there. And only one person attending with a very big, powerful team of HIV specialists. I was feeling really ashamed, but Dr. Ganga Kedkar, he said, no, even if one person learns from me, I think I'll call it a day. And he gave a lecture to only one person. So that's how that particular person in. And again, he didn't feel ashamed of everything. He went to visit Gadikhana. Gadikhana, it's a small hospital, government hospital. So when I went there first, he was sitting in the chair. Ek lahan mulka, who was from the slums, he was beside. Mother was talking to Dr. Ganga Kedkar sir. And that child was at the stethoscope, he never got angry, Many doctors get angry. No. He let him play. And then he put his hand over the child's head and said, what is your name, Bawaz? So I was serious, right? Whether you are coming from any community, for any patient, any human being such as, he has got a great passion and great love for them. That's what I like about Dr. Ganga Kedkar sir. So just wanted to share with you our experiences, our Mukta Charitable Foundation's experiences with Dr. Ganga Kedkar sir. So thank you very much. Thank you, Mukta team, Jayasri, Mansi, Rupa, and of course, our White Coat team, both of them. So Nanore and Ganesham ji and all of you, of course, you are coming in great numbers as usual, and you have got a great line of questions also. Those questions were really, of course, high quality. Everybody can say that. And you can, of course, guess Dr. Ganga Kedkar's knowledge, because when he gives a lecture, it's fine. Yes, he had to stick to some times, he had to some questions and some slides. But look, Mansi Apadi asked him a question, and how much in depth he answered that particular question without any preparation. So that's how Dr. Ganga Khedkar is. So thank you very much. Thank you, Rupa. Shall we conclude, Rupa? Right. Okay.
Yes.
Okay. Thank you very much.
Yes.
Thank you, everyone.
Thank you, sir. Yes.
Pratik, we can conclude the meeting. Chandan आहेत ना?
Yes.
Yes. Thank you so much, Chandan.
Thank you.
We can
Thank you. Bye.
conclude. Yes.
Okay. Thank you.
Thanks.
Shall I end?
Yes, please.
Okay.